So I want to switch up the format a bit. It's the last hour, and I know what it's like to stare down the barrel of the last hour of an engaging conference. Sometimes you're a bit mentally exhausted, and so today we really want it to be collaborative. And the panelists have asked that this be a collaborative event, and so I was going to take my jacket off and roll my sleeves up, but we just had a break. So instead, I'm just going to sit down and we're going to introduce the panelists. And then what we'd really like to see is for you to queue up behind the microphone and ask as many questions as you can. And the reason for that is data and communication is probably the one thing that affects all of us in every single area. It's very germane to health systems and independent practitioners in third world countries and urban areas. And so we want to make sure that you get an opportunity today to ask these individuals questions because they really are on the leading edge of technology. So let me just grab the microphone here and introduce them. First on the far left there, we have Dr. David Kim. He has a medical degree from Johns Hopkins University and an MBA from Stanford University. He worked in venture capital for over 10 years. This is him right over here. And right now he's the COO of Lumiata, which is a company down in California, and they have a medical graph. They just made news with a medical graph that that mimics multidimensional human reasoning. Here on my left, we have Dr. Alex Philp, who has his Ph.D. in historical biogeography and geospatial systems, as well as a master's degree in history, geography, and ecology from the University of Montana. He's on the board of Providence St. Patrick Hospital, as well as the board at the system level for innovation technology management. In the middle here, we have Ryan Gunhold, who is with the Bill and Melinda Gates Foundation. He's working on a Ph.D. in human and organizational development from Walden University. He's been recognized as an innovator in the Chief Learning Officer magazine, as well as Avanade. He had a recognition with them for excellence in diversity and inclusion. So those are our panelists, and again, they'd like you to participate today. I just want to set the stage really quick on what we're going to talk about, and then I have 9 questions over 60 minutes. And hopefully by the time I'm through the first question, we'll have a lineup behind the microphone. The first industrial revolution used water and steam production, or steam power, to mechanize production. The second used electric power to create mass production. The third used electronics and information technology to automate production. Now a fourth industrial revolution is building on the third, the digital revolution that has been occurring since the middle of the last century. It is characterized by a fusion of technologies that is blurring the lines between the physical, digital, and biological spheres. The possibilities of billions of people connected by mobile devices with unprecedented processing power, storage capacity, and access to knowledge are unlimited. These possibilities will be multiplied by emerging technology breakthroughs in fields such as artificial intelligence, autonomous vehicles, the Internet of Things, nanotechnology, biotechnology, material science, energy storage, quantum computing, and of course, healthcare. So with that, I want to start my first question to Mr. Gunhold.
Thanks, Paul.
I know that changing global health through education remains a passion of yours, and would like you to comment on how this fourth industrial revolution is contributing to healthcare innovations in developing third world countries, and what forums exist for leaders to come together to discuss the projects, problems, cultural perspectives, and this technological revolution. And I think you have a slide here.
I do.
Okay.
I thought it was a lot better than answering a paragraph. I was hoping it was. So as Paul's putting that up there, some of the challenges that the Bill and Melinda Gates Foundation actually has in regards to this area is actually something that, as Paul has already noted, something we all have on a common everyday basis. Those challenges, however, are also compounded by the fact that in a lot of the places where global health is provided by the Bill and Melinda Gates Foundation are places that are quite remote in their area. And so this first piece that you guys are seeing, you're seeing a great visual of some of the work that the IT department actually is working on, and I wouldn't think that it's much different than what you guys might actually have or be working with in any of the groups or organizations you're working with. But that first bit that you guys actually see at the top has a lot to do with the fact that if you don't have even a mobile connection in very remote places, it actually becomes more and more challenging to be able to provide just basic services. And so connectivity has become something that has grown tremendously in recent years. And it's something that the foundation has done a tremendous job in looking at new innovations to allow for doctors in the field to be able to connect remotely using their mobile devices with their remote computers, even all the way back in Seattle, to be able to look up a simple article that they might be able to reference to provide the kind of care that they need to in some of these remote locations. So that would be number one that I would definitely say. Number two has a lot to do with the collaboration of that, who's included in those discussions, and some of the challenges that we have with that, especially again in very remote locations, are not everyone has the ability to be able to access that information. So there are numerous initiatives that the foundation actually uses to ensure that everyone has some type of access to the same information globally. And why the reason they're trying to do that is because the foundation is solving a lot of problems through joint initiatives that are happening globally all at the same time. It's very common for a breakthrough to actually happen in these online communities. And when they do, for those of us who were able to hear Lee Huntsman last night, that breakthrough has a lot to do with just the ability to be able to share the information that we have. It's not any new information that we had to go research. It's just connecting the right people and the right resources have made significant breakthroughs in a lot of the work that's happening for global health. And then I will say, just last but not least, the lower portion of that has a lot to do with the initiatives that can include and be more inclusive of other people. So a lot of the times the foundation gets requests that allow for other individuals to partner with, to share resourcing and to share a lot of the knowledge and a lot of the breakthroughs that they're having, rather than to have to wait for some of these doctors to come back and actually have to publish their results of what's happening. So that's a similar model of what we commonly see happening at the foundation right now, Paul, but I know we had some further follow-up questions as well.
We do. I think I'm interested in, the explosion of IT in the healthcare organizations. Many folks have implemented an EHR, and then, they've come with a risk platform to understand how risk occurs. However, there's other really adoptions of IT that are occurring, and so I know, Dr. Philp, you're involved in a predictive analytics. Dr. Kim, you are as well, and so I think I'd like you to talk about, if you could, how your predictive analytics understanding of data and big data is really going to drive the healthcare conversation in 6 months, because in a place like Montana, we might not be aware of that. So either one, go ahead.
I do.
Yeah. So the company that I am associated with is a company that is trying to do something that is somewhat daunting and somewhat sci-fi, but we are actually developing a medical artificial intelligence. Basically, when you have a conversation with your physician, they have a certain way of asking questions because they come with a certain knowledge and experience that they understand that with this information, they will know more about what's currently happening with you and even may predict what's going to happen to you in the future. So they're just gathering all the medical information about you, and it may not be just clinical information, but it's also social information. It could be financial information that gives them a better sense of who you are and what are the healthcare risks that you're facing. We actually are creating a technology platform that really encapsulates that physician intelligence. And now, with that platform, we're able to take individuals' data, and it could be anything from claims information, your laboratory data, the medication use history, We even took your Experian data and EMR data. And then what we try to do is now, with that information, predict at the individual and actually at the, what we call ICD-9, but at the disease level, what is your risk of developing a certain disease, let's say chronic kidney disease or congestive heart failure, now, 6 months from now, and 12 months from now. And with that, you have the ability to actually get a better assessment of the risk of a certain population of people. It allows financial institutions to make plans. It allows provider groups to target those people at high risk for certain disease that you better manage their chronic diseases. But these are basically application of all of the new information that we're getting, because there's clear movement of, healthcare will used to be paper-based cottage industry. It wasn't that long ago when, EMR was just a thought. Now everyone is being pushed to have EMRs in their system. It's meaningful use, and basically you were encouraged financially to convert into everything to be digital. And now, I think most systems are. I just heard a few hospitals that are still paper-based. That's what I used to do when I practiced. But now, everyone is doing things electronically. It could be EMR data. It could be your Fitbit that you're wearing, or your Apple phone that you're putting, your information into. There are now, the iPhones are no longer just a tool for you to get information, but it also collects information about you. And everything from how you're doing with your sleep all the way to your activity level. And all of that information will now get integrated into how you are as an individual. Genomics information, biometric information, EMR information, and that information will get aggregated and used to kind of assess what your health risk going on in the future. And I'm happy to say that we are part of that movement, but there are clearly a lot of other technologies, companies that are also very much involved in this.
So I'd like you to jump in as well, but the one thing I want to ask you to answer is, integration, right? We have many healthcare systems implemented Epic, and then they bring in something like a Crimson, and it takes 6 months for a platform to get integrated into the healthcare system. And so for many healthcare systems to think about, oh, gee, we're going to bring in Upstream research or Lumiata, it's overwhelming and it doesn't make sense. So can you talk about the integration as well as the...
Yeah, thank you, Paul, and I also want to thank my fellow panelists. It's great to have you guys here in Missoula, and I know you grew up here, so welcome back.
Thanks.
Fellow neighbor from the Snake, and I want to just also say that I've been incredibly impressed with the quality of the speakers and presenters yesterday into today. It's yet again another brilliant Mansfield conference, and Dr. Kim and his team really should be thanked. Two things real quick. I want to talk about the fourth revolution and the data reservoir information. So I've had the luxury or the privilege in my career at the University of Montana and as a graduate of being exposed to lots of problems in big data, lots of opportunities. And when I was here 20 years ago and we were looking at satellite imagery, we thought a gigabyte was a lot. We thought a megabyte was a lot, really. And now we're looking at problems, 20 years later that are just exponential in terms of growth. A useful way of looking at this data lake, or literally the fossil fuel of the future is being described as digital information, is to think about its volume, literally the size, the velocity, and the variety. Now these are very standard terms that have been out there now about 4 to 5 years. Gartner came up with these terms to describe some lexicon of big data. And so if you listen to anybody, you can often hear them describe these different dimensions. Increasingly, you hear another V called veracity, truthfulness, authenticity, metadata dynamics, da-da-da-da. The fact is, the healthcare industry, health, global, national, regional, is undergoing a massive revolution in terms of its digitization. I call it a barcode. And having grown up in a medical home, my dad refused to buy a computer. He refused to ever deal with anything digitally. He had 39,000 charts in his office when he died. And at the end of the day, the industry has been analog. It is now becoming fully digital. To Paul's secondary question about integration, as I've looked at the healthcare industry, especially electronic medical record systems, the explosion of companies that are building apps, from significant to simple apps. And to Lee's point yesterday, a lot of them are going to struggle trying to bring that, that capability into the art of medicine. The hospitals are one of the most complex systems on the planet. But putting that aside, I've been shocked and actually dismayed at the level of lack of interoperability, which means things work together easily. The accessibility issue has been abysmal. And I actually just sort of shake my head when I see colleagues at the hospital where I'm on the board struggle to even get a report out of the very system they spent a lot of money on. To me, that is actually regressive. That is not progressive. It has nothing to do with the digital transformation. And I spend a lot of time worrying about access now, security, and literally usability. So the question I would ask all of you is, how useful, how progressive is if we build a system but we actually can't get the information out of it? Or there are individuals that are specially trained to get it out but everybody else can't. Or the issue of privatization of the information, because if you read the contracts and you read them very carefully, your information is becoming someone else's information. So we worry a lot about Snowden, and we worry a lot about the government. I would suggest you might want to consider what's happening to your information. Now, there are debates and discussions about this. It is a dimension of healthcare systems and informatics, and that's what I worry about. I think the goal of technology, and this is the final thing I'll say, and I've spent most of my career building things with really, really smart people, and I'm really fortunate, is tools, technology should be useful. It actually comes from the Greek word techne, which means tools. And it needs to be something that allows you to do something better, easier, faster, cheaper. Think of it like building a house. If I was going to build a house and I had a bunch of tools that did not help me do it, would they actually be tools? Or would they be impediments? So the first rule, forget about complexity, forget about all the big data stuff and analytics and blah, blah. Think about whether or not any of this stuff is actually helping you do something meaningful. And in the case of healthcare, it ought to be the timely, effective delivery of a service at good value with expected outcomes in a measurable way. And we spend a lot of time worrying about that. So that's my first response to a great question. Thanks.
You bet. Dr. Kim, can you tell us, I want to move to the rural setting, which is 15%, 1/5 of our population. How do you believe that the data and communication revolution is going to change the situation really in rural America?
Yeah, thank you for the question. And in fact, the global conversation that we had earlier today kind of leads to this. But ultimately, it's going to depend on a certain amount of infrastructure that needs to be available to the rural area. And unfortunately, I think that the rural America is catching up, but it's not at the level compared to the metropolitan area. It's to access to either cellular, signals or to broadband. If you could get that, talking about access before, you'll have plenty of access to technology, and the things that we have, available, at least in healthcare, is pretty now growing literally on a week-to-week basis, because the whole area of telemedicine is becoming just widely accessible. Now, unfortunately, policy supporting telemedicine versus the technology that could actually support telemedicine is two separate things. But the technology-wise, whether it's video chat with a specialist or video chat with, and in fact, to a doctor somewhere else taking care of a patient in the ICU, to just handling how you do a cold, it's widely available already. It's just that the question comes to who's going to pay for it. A lot of the telemedicine is out of pocket, which for some people that's not a good option. What we bring to the table, in fact, at Lumiata, is that our intelligence is actually an engine for a company that has created a user interface that anyone could get on, and they type in certain information and then start describing what medical problems that they have. And in the background, as we get the information, we actually start to generate the list of questions that will allow us to create a differential diagnosis. And we will come back to say that, okay, the next question is going to help us increase the probability of one diagnosis and decrease the probability of another. That type of kind of interview is the same thing what a physician would do in their own heads, but we're actually doing that in the background. And what this allows you to do is now, if you actually go through the process, this will serve as the kind of a template for a nurse practitioner or a doctor to say, I choose this because it makes the most amount of sense. And what, in the end, what it does is it actually increases the efficiency of delivery of healthcare on a virtual basis. And asynchronous, meaning that it doesn't mean that you have to wait for a doctor to be available to have that conversation. You could have it at asynchronously, meaning that you type information and you get it later, and you could actually act upon it at a time that is convenient for you. So that type of technology is now widely available. So it's video chat. Teladoc does a lot of video chats that you cross state lines, and then all the way up to the ICU care. So that kind of now, technology is available, but the question is, are they incentivized to actually use it? And that's I think the next kind of policy question that's going to come about.
So you introduced two concepts there. Really, one was the community collaboration that I want to touch upon, as well as the legislative piece. Right. And so I have a question for Mr. Gunhold on the legislative piece, but before I move there, I just want to ask Dr. Philp, I know the community collaboration with Upstream research, that's been a focus area. Can you tell us why being able to understand community collaboration or community benefit is important beyond just the CMS regulation, the offering that came out recently? Can you speak to the benefit of that?
Well, I can try. So I work right now for a company called Upstream Research, and we picked our name ridiculously intentionally in the sense that when we looked at the health landscape today, we felt that one of the good areas we could focus on for savings was literally prevention. So if you think of upstream, you just have to think about looking at early causes and conditions that may be contributing to disease at various scales. And we are trying to figure out that at a community scale. Now, community is an interesting word in the sense that it oftentimes has to be tied to some physical geography. So I'm a geographer. So when I think of community, I look at trying to define that. Do we mean a community of 2? Do we mean a community of 10,000, 100,000? What scale do we mean when we talk about community? Well, medicine has a particular answer for that. Epidemiologists have a particular answer. But to Paul's question, there is an explosion right now of the desire to not only do the analytics and the communication and the sophisticated stuff that's being described here, and this is significant work that Dr. Kim is mentioning, and obviously the Bill and Melinda Gates Foundation is, I think, #1 in the world in terms of trying to move the curve here. But ultimately, bottom-up approaches, looking at local scale, looking at what's going on in your community in terms of resources are ridiculously important. Every major large healthcare system we're aware of, and we've talked to a number of them, are looking for those community resources that can help improve lives, improve quality of life, and ultimately reduce disease. So for instance, the park structure in our neighborhoods. How much do we walk? What are the riding systems like? What are the sidewalk systems like? Where are the daycare centers? Where are the YMCAs? Where are the food stores? You've heard of food deserts, so people are looking at food access issues. They're looking at drug addiction centers. They're looking at alcohol treatment centers. They're looking at a variety of things that are in our community that ultimately represent resources that we're spending money on from various sources that can help us look at not just how we manage our sickness and get better, but ultimately how we're managing our lives towards wellness. And this is a real spectrum issue. It's ridiculously complicated, but I would say that you'll hear terms like community health needs assessment, which is a federally mandated effort. First of all, assess what we have, where are our problems, and now you're seeing a transition to not only assess, but how are we going to begin to intervene? And intervene is a fancy word for do something, moving into action, given the limited resources we have. We actually have, in certain cases, with obesity, diabetes, dementia, Alzheimer's, cardiovascular disease, obesity, certain diseases, we have these diseases increasing, but we have decreasing resources to try to focus on the prevention. So I think what you'll see in some, I think you'll see increasing efforts on the part of healthcare delivery systems, hospitals, along with insurance systems and private employers, beginning to try to look not just at the healthcare system, but the community system. And it's that community system that ultimately represents that fabric, literally, that we need to begin to weave together in order to create the healthy lives that ultimately are the most cost-effective way of reducing expense, but ultimately improving the lives. So we don't want to just look at this in terms of doctor visits. We'd like to integrate wellness into our lives. And that is a fundamental thing occurring in this country. Other countries know this well, but I think it's very, very exciting. And then we can get to really know our communities.
That's what Dr. Garrity had mentioned this morning. That was the first thing that she had brought up to all of us this morning, introducing that concept of where you live matters with the map and the geospatial. So, Mr. Gunhold, technology is advancing more rapidly than legislation and regulation, which Dr. Kim referred to earlier. Is there a scalable IT solution that could help drive the legislative conversation to unlock global opportunity? I always give you the difficult ones. I think about finance systems.
I'm doing my dissertation right now.
I think about finance systems like Visa, MasterCard,
Yep.
something we all know.
Yep.
Yep, so that is the question, sir.
So would you mind advancing? I'm such a visual. I think maybe working at the foundation for a while, we just love to teach. That one is perfect. No, I don't know of that perfect solution yet, but I do think that there are some breakthroughs that are happening right now. The reason I share this particular visual is this is one of the best ones that I have seen to date. And it was a solution that was actually created from Accenture, a very large consulting firm you may or may not have heard from, who implemented it actually at the foundation. The biggest problem actually at the foundation, and this might sound really crazy, is that they struggle to give their money away. And so what I mean by that is it's very difficult competition in which to choose and select the programs by which they want to fund. But because of the size of a lot of these programs, it's very difficult for them in an annual year to try to give $6 billion away. And so they have created these systems for that very reason. And though it's not creating legislation, so to speak, what I will say is they have an underlying piece that I think is very innovative, and there's more agreements that are happening now in how they provide those programs through all global health that I think we could all learn from. And one of those things is exactly what Alice is speaking to here, which is when we know what each other is doing and the resources we're using, if we can actually pool those resources together, we can actually help a lot more people, which just totally makes sense. And so when we know how often those are being provided, when we know who the single individuals are who are providing it, we have greater opportunity in which to do that. Now, one thing I will say that I actually think is a pretty good system is when we all go to actually use our healthcare programs and things of that nature, Blue Shield is a great example of this. Being able to find a provider seems to be actually pretty easy for us, right? But we are not always clear whether or not the ratings of that, whether or not there's simple solutions that might actually get to. We all have to go and pick and choose to find out what the right solution is going to be for us. So I think this is a great step for us to move into that type of direction, because I think people are going to be the ones who move this forward. And I know you mentioned the finance solution. I think that there is an underlying piece of that too, Paul. Actually, I think that when we see that there's more feet, if you will, that are getting the funding for what's happening, it's more likely to move more people forward. And I think that that reciprocates also what Dr. Huntsman was actually talking about on the previous night, that we'll actually see that shift happening, and we're very close to actually seeing it happen now.
There was something you said earlier and something that you guys mentioned earlier that I just wanted to go to real quick, and that is the challenge, again, back to this urban-rural divide. And I don't disagree with anything that Dr. Kim said. I agree, but I know, having lived out here in Montana for 29 years and looking at some issues, one of our clients is Virginia Mason. And Virginia Mason, in particular, was super interested in rates of pancreatic cancer. Rates of pancreatic cancer are increasing in the U.S., and people have lots of hypotheses on why. One of the things we looked at, again, using the kind of tools that Dr. Garrity was showing earlier, was we just looked at all the counties in the country that are technically defined as rural and all the counties in the country that are technically defined as urban by the USDA. You know, density population counts. It's very simple. And when we looked at the distribution of rates of pancreatic cancer, where there was 1 or 2 standard deviations above the national average, the association spatially between rural areas and high rates of pancreatic cancer are surprising. Moreover, the mortality rates are significant. Basically what I'm saying is that if you are in rural America and you're diagnosed with pancreatic cancer, you have a significant increase of dying of that disease. And there's a lot of questions that raises. And we don't have all the answers to that, and I want to be very clear on that. But first thing is just identifying the problem. Second of all, I'm convinced that folks in rural parts of the United States, it might not just be a function of their income. It's, again, functions of access. It's a function of how often they're getting screened. And obviously, one of the major factors in pancreatic cancer is how early the detection occurs in terms of increasing your survivability. So all these things are kind of compounding around what could we do from a community resource perspective, what could we do philanthropically, what could we do with organizations and corporations like yours to try to extend care in ways that are, again, are preventative. It's one thing to be dealing with the outcome of that person, unfortunately, being diagnosed with stage 3 or stage 4, but it's another to try to figure out what we could do to screen, to be getting proactive, to actually be reaching out. And that's my big mantra with healthcare systems, insurance systems, and any of the payer mechanisms, including government, is let's try to figure out how we can get into earlier identification of the risk and therefore earlier intervention. On the one hand, it increases the survivability of a disease, which is good for families and individuals, and it's easier to treat. Second of all, it reduces cost. And thirdly, it has less a detrimental impact, and now you start to talk about wellness again within communities that are just basically on the margins. Final point, I was blown away today by the maps and the work that was done showing, and I read the New York Times article this morning, showing where you live and what that does in terms of your life expectancy. Now, we've known that in Montana based on the Native American reservations. It's actually really, really abysmal and almost a travesty what goes on. But if you take that concept and expand it, I'm very encouraged by what you guys are saying in terms of how we can bring these solutions to bear. So that's my response to that.
If I could follow up. Actually, when you talk about pancreatic cancer, I was like starting to get the physician side of me saying, because I went to Johns Hopkins where the Whipple, which is a primary treatment for pancreatic cancer at the head of the pancreas, it's a 5-hour surgery, called Whipple's procedure. And I just remember being in the OR as a medical student, and all you have to do is just pull the opening of the abdomen for 5 hours. And I just remember brought back kind of actually not so great memories, but it's true. It is for that, it's early detection that will allow you to get it, potentially for potential curative treatment versus a palliative treatment. Right. But actually, I want to go back to what Dr. Huntsman has brought up. And this whole area, or the whole idea of movement from value-based or volume-based to value-based, I would say delivery of medicine is pretty significant. It really is. And fortunately, we at Lumiata is a beneficiary of that, because when you have a situation where now the alignment is that you have a certain amount of resources that you need to deploy intelligently to the population that you are at risk for, that has a certain different behavior than if you were aligned to just do as many procedures as possible. So when you now have limited resources, what you're trying to do is, okay, how am I going to best use those resources to capture the most amount of value? And for us, we believe that the first step is you got to know the population that you're dealing with. You got to know as much as you can about the risk of these people developing certain diseases by getting the most amount of information. And it's all out there. It's like, you know, if you give a doctor 4 hours to do a complete chart review on your past medical history and all the other information about you, they're going to come up with a really good idea of what they think that you should be doing to optimize not only your medical situation, but your wellness. This is the way you should develop your diet or the lifestyle changes. They will have a pretty good plan. And what we're trying to do is now, when we have digital information about you in the form of EMR or claims information, that allows us to do an assessment at the individual level to say, hey, this is the likelihood of you developing certain diseases. For example, if you had long history of, you know, hypertension and diabetes, you're at a higher risk of developing chronic kidney disease than someone who has no past medical history. Or if you have a history of ischemic cardiomyopathy, there's a good likelihood that you're going to develop congestive heart failure over a period of time. And that's what we're trying to do, is we try to assess that individual risk at the diagnosis or the condition level. And having that information, now you could start to do those things to intelligently manage the individual and therefore the population. And it goes all the way down to how do you best live a healthy life that could optimize this person's wellness, hopefully not to the point where they actually, you know, have healthcare issues. So earlier preventive work, and I think that the movement is going towards that direction, because now the shift from, you know, volume-based to value-based care.
I think that's a theme we've heard all day today from Dr. Huntsman, from Dr. Garrity, how the healthcare landscape is shifting. And one of the things that Dr. Huntsman said was, you know, hospitals are going to become cost centers. That's just the reality of the future. And so to hear these gentlemen speak about tools and predictive analytics tools and how we can actually assist the physician with diagnosis and smart diagnosis using big data is truly an inspiring thing. I want to just shift for just a minute here and talk about population health, because we've talked a lot about fee-for-service to fee-for-value, and this question's for you, Dr. Philp. I promise it won't be too Ph.D.ish here. Population health is a buzzword that appears to have created a gridlock for health systems to focus on historical data to provide the initial context for how we all understand patient care. With your background in the geospatial environment, how can we use this fourth industrial revolution to create a future in where patients, providers, health systems, and governments are focused on our future and into a more proactive role?
Yeah, well, it's a great question. So a couple things about the words population health. When I first started hearing it about 3 years ago, and we were getting lectures from the McKinsey group or all the consultants out there basically advising people on the tidal wave coming, the sea change occurring, literally the entire harbor changing. I was really fascinated by that term, because as a geographer, I felt that I might be able to contribute something to a discussion about a population across a landscape, a community, an environment. That's what many geographers do. As I got into it more, though, I found that there's about every organization has a different definition of population health, which makes it very, very difficult to have a discussion, because when I say pop health, the other person's hearing something completely different. Generally speaking, healthcare systems, for instance, see population health as being, what can I do to better service my patients, and what can I do to better service the new patients that I desperately need in order to maintain the volume growth or the tension between the two business models. Fee-for-service isn't over yet, guys, I can tell you that. But at the same time, there's massive experimentation for outcome-based or value-based medicine. So they have to compete with those competing business plans that Dr. Huntsman described. Second of all, they're very leery, as a general sense, on the general population. When they say population, they don't mean everybody. They basically mean our lives, our covered lives, or the lives we're serving. And that took me about a year to figure out. I thought, wait a second, you said population. No, no, our population. Then this gets worse when you go and talk to the insurance companies, because they definitely know what they mean when they talk about their population. They know you down to a level of detail that you would find surprising, because they've got all your claims data. If they don't have claims data on you, they really don't know what's going on, and they shoot in the dark, and now they're back to death tables and actuarial tables, which are fine, but that's when they ask you questions like, how much do you drink, what do you weigh, and what do you smoke? Those two behavioral issues and the physiology of your body mass index can tell you a whole lot about risk at the phenotypical level. And then if you go into government and you talk to them about population, well, now you have a whole nother discussion. Our poor friends in public health are struggling to try to do the right thing. They're being resurrected and rediscovered. Remember the public health system in the US? We defunded it over the last 30 years, by the way. And then we have a thing called the federal government with Medicare and Medicaid. They're trying to figure out how to look at this changing landscape. And now you have the states. So the feds are shifting risk to the states through mechanisms like Medicaid expansion, Medicare expansion, and we're all trying to figure out these different risk distributions against disease, against things like wellness, over and against this term population health. By the way, do not confuse population health with community health, although those are coming together, and be prepared to have discussions about where population health meets community development. And those discussions are now happening in very interesting ways. So I think we're looking for, I would argue, some better definition or common reference, or at least when you sit down and have discussions, you at least have a definition of what you mean by pop health so you can figure out the ambiguity. Second of all, to Paul's question, I would love to see dialogue occurring between all the stakeholders, but I don't quite see that happening. I see territorial redistribution, I see market resize, I see, again, basically a redistribution of wealth and payer mechanisms, and I see a very disruptive ecosystem where everybody's trying to figure out the new platform. Final point. Given what's going on, and I would be interested in anybody's opinion on this, but if you make observations, generally speaking right now in the healthcare landscape, about 3 trillion, 18.5% of our GDP, a lot of money, you're going to see one thing, you're going to see consolidation, and you're going to see massive M&A. Look at what's going on in pharma, look at what's going on in healthcare providers, is get big or get out, and even in insurance, they continue to grow and aggregate. The reason is they're taking on risk in ways they've never done, and the one way you can spread risk is over volume, okay, and those kind of things. So I have sort of my philosophical dream. I'd love to see those are the kind of conversations Upstream's involved in, but I don't think we're quite there yet, but I think we need to be.
We have about 14 minutes, and I wanted to talk about experience economy. When you think about Yelp, that's an experience economy platform. You know, everybody in the room, or a worldwide ranking, TripAdvisor, Angie's List, those are experience economies. And many articles that I've read indicate that healthcare has to move into an experience economy in order to change. So I'd like your thoughts on this. When I think about that, I think about a personal health cloud, in where patients are able to exchange data with other patients, coordinate their care, design their own permissions, and provide star rankings on providers. I know one of the big healthcare systems in the country right now has a star ranking, but they use it internally. And so, Ryan, I'll start with you. What do you think about healthcare moving into an experience economy? And do you see any IT platforms that are driving us in that direction?
I don't know the platforms right now, Paul. But I think it's a great idea. I mean, some of the ideas we've heard here over the last couple days are definitely alluding to this fact that it's going to be, it has to be the driving force. I think we have allowed on numerous occasions for it to try to be legislation, for it to try to be many other things that have not been successful vehicles for us. Whether that's like an Uber of global health, great. I think all the better. All I would say is my only concern would be that quality of care is always maintained in some fashion or another. So I do love the idea of a rating system. Those that are starting to exist more and more are extremely popular. And I think we see that across the board when we look at things like Amazon. I used to be a store shopper myself a lot more than an Amazon shopper, but that has greatly shifted. And I personally myself, a lot of that has to do with the customer rating more than anything. The ability for me to be able to see that what other people like, and that there is quality to that service, and that it's helped provide value. That personally for me is all I need to see. And I think the crop ups like the Yelps and Ubers and Amazons that are all out there, that seems to be what's driving them more and more.
Yeah, and I definitely want to leave time for some questions, but I want to take a little bit of a twist on that. We mentioned earlier that medical devices is an area where it's actually undergoing something of a revolution. In the past, and I actually used to be an investor in medical devices, and I used to also follow as an equity research analyst at the investment banking level. It used to be a highly lucrative area where the gross margins were really high and the net profits was very high. Those days where you could actually start to charge at an excess premium to, because of improve the procedures, those days are kind of over as we, again, go from volume-based to value-based. And now you're limited in what you want to spend on an individual for, let's say, spine surgery, or for knee surgery, or for any kind of cardiac surgery. Those days are so that now there's tremendous pressures on price control for medical devices. So what the medical device companies are doing now, is going to the experience, is that instead of selling the hardware, they're selling the service. So for example, for congestive heart failure, a company called Medtronic, probably heard of Medtronic, they have many devices for the congestive heart failure area, but they also have a defibrillator that allows you to actually improve contractility for those patients with certain type of congestive heart failure. So what they're doing now is, in addition, they also have a diagnostic component where they have devices that could actually see how well you're doing with your congestive heart failure. So instead of now selling just the devices, they are contracting with providers or payers to say, I will take care of all of your congestive heart failure patients. I am going to own that disease for you, because that is one way that they could actually maintain the kind of the premium. But it is, again, one of those things, no longer are you just selling the goods or selling the commodity, goods that are not becoming more of a commodity, but you're selling the whole experience or the whole treatment of that certain disease process. And that's going to happen for congestive heart failure. It's going to happen for diabetes, as these people are trying to do. Same thing is happening with the laboratory, big laboratory test companies, the LabCorps and the Quest of the world. Even though they charged a lot of money for these labs, what they actually get paid by the insurance companies is actually a fraction of what they actually charge. And because of now those things are becoming more of a commodity item, they are looking for other ways to incorporate their lab tests as part of an overall solution or a service that they're going to provide to either the payers or the providers. But it's going towards that whole experience. It's no longer just the goods, selling the goods. It's selling the whole solution or the service.
Very interesting. So I trust if you have a question, you'd be at the microphone. So if not, I'll just tell you. Oh, go ahead. Good. I was just going to tell you a story about my brawn toothbrush, how it can talk to the dentist, but you go ahead.
I'll try and leave some time for that. That sounds fascinating. Thank you all for the panel. I have so many questions, but I'm going to wrap two together and kind of cheat a little bit. You guys have kind of touched on it, but if you could extend maybe some answers. With the wealth of the new data that's being collected, either by ourselves with the sort of DIY data science, the quantified self movement with citizen population, and then also just with our medical institutions and whatnot, why is it, in your opinions, is it so hard to get beyond the silos and share that data, and especially with me, my own data, if I'd want that same access to it that my providers and the payers have, and then on top of that follow-up, if it is my data, Dr. Kim, is the derivative data set mine as well? Do I get access to that and the sort of, or is that something, I realize you have a business model to support, but.
Yeah, so the answer is yes and no. So the yes part is you could get access to your data but however, technically it's not yours. Okay, it's owned by the service provider who creates the information. So, and ultimately it's owned by the person or the organization that pays for that information. So actually it's your payer who has that. Now, even the payers don't have access to the EMR because that's actually owned by the provider. And so they have to actually, have an arrangement with the provider to get access to that data because, either they pay for it. If they want access to your medical records, there are situations where they pay the provider specifically for your medical records so that they could do their billings correctly. Or if they paid for an imaging study, then they will get the results. Or if they pay for a laboratory, for you, they will get the results of that laboratory. Now, you can get access to your information, and a lot of these organizations are providing ways so that you could get access. So now, many provider or networks will give you your own access so that you could get access to whatever information that, either their notes or summary of their notes, and sometimes the laboratory information that they have available. They're trying to do that as more of a customer service and not because they feel like you should have it, okay? It's just, now there are legislations and policy changes that are trying to force the information to be shared more widely, but I don't think that, at the end of the day, I've been jaded by my years in venture capital. You have to follow the money. You really do. Who's being incentivized by financial incentives to do what? And in this case, they're not quite there to do that, other than that they want to improve the customer service because ultimately, their customer survey is part of the quality metrics that you're going to be also filling out. So to them now, there's some money behind some of the actions. So I don't know if that fully answers it, but it's still a mix of whether you're going to get your data or not. There's certain organizations that you get a lot more data than another organization where it's still the best way you're going to get it is a fax copy of someone's written notes.
So with 5 minutes, do you have a question, sir?
So I didn't get a chance to talk too much about innovations in disaster medicine and preparedness when I gave my presentation. But Dr. Kim, you talked about telemedicine earlier. In Haiti, where you had almost a complete collapse of available healthcare and public health infrastructure, telemedicine and telebehavioral health proved to be enormously important force multipliers in our ability to deal with an overwhelming population in serious need of care after that crisis. I'd be interested in any of your comments about, what's the future here and how can we integrate the IT arena and folks in the preparedness space so that we can come up with more plausible solutions that we could rapidly deploy to areas that are affected by major disasters.
Yeah, so let me just answer quickly, and I'll let my colleagues answer the rest. I have to tell you, it's not a technology issue. I mean, so again, going back to Dr. Huntsman's comments, the IT harbor has a bunch of technologies. The healthcare area just haven't adopted it yet. So it's not a technology issue. I mean, the technology that we're using right now to build our technology has been around for a while, and it's been used for a while. And it's just being now adopted for the healthcare use. So I think that all the things with telemedicine, whether it's video conferencing, whether it's access to data, it's all there. Is ultimately what are the incentives that allows you to really push forward those uses of the technology. I don't know.
Yeah, I'll add to that as far as technology is concerned is it seems that in a lot of these situations with healthcare, they're using very expensive technologies, and in a lot of them, they're not really being pushed to innovate. So as far as incentives go and areas of technology focus, it makes it really hard, in my personal opinion, for great new products to come out for the medical and health industries when they're using a lot of the technology that was outdated maybe 5 or 10 years ago.
Two things about your question that interested me. One, and I think you brought up the word and would know this as well as anybody in this room, is resiliency. So I think it's incumbent upon nations, states, cities, others to think carefully about some type of resiliency plan and their ability to recover the rate of recovery from a natural disaster, or the proper term now, I guess, is some type of natural event. I don't see, I think information technology, bandwidth systems, communication systems can be overwhelmed very quickly. And so therefore it's hard to get responders in that and so on and so forth. So I think resiliency planning matters. And then something else you brought up, which I think is important, is that in Montana, when we had the Ebola scare, I just want to make everybody be aware of this. We have a hospital here in Missoula that has a bed that is designed for containment and treatment of an individual with a level 4 disease or something like that. And just the hysteria and the misinformation and disinformation around that one disease, that one person showing up in Dallas or Emory, was, really caused a lot of problems and a lot of wasted energy and time. Imagine if there was actually something significant. And then the final thing, which I don't hear many people talking about, but it addresses your question in part, is the cybersecurity vulnerabilities associated with mainstream health IT. Every day, major insurance providers, major healthcare systems are getting hit. They're getting hit hard. I think about 2 months ago, there was 300 million records taken. And by the way, a lot of those are ransom attacks. So you're not going to hear about them because they're going to be quietly dealt with. Now, you take the cyber vulnerabilities and you apply them to devices, and you apply them to very poor IP addresses and username passwords and backdoors associated with this innovation, so-called Internet of Things in hospitals. I wouldn't want to be in a hospital right now, let alone with dealing with disease, let alone, I'm a hacker's dream, if you really want to know about it. And unfortunately, I think you'll see a rise in that in the next year or two from both our EMR as well as direct attack.
I would say that's a good industry to be in right now, because we have such a high bar that we have to meet in order to satisfy our customers that we have our security, in gear. And it literally is, something that we have to work on literally on a day-to-day basis, make sure we're compliant with all that. But despite that, there are things that we may just not know of. So I do agree with you that it's a little bit scary, because we can't buy enough insurance for that, to tell you the truth.
This is a field that's very exciting, and if you go on Google and look at machine learning for healthcare, you'll find all kinds of applications and companies like Lumiata or Upstream Research or Ginger.io or all these other companies that are truly transforming healthcare. So I want to thank our panelists today for the engaging discussion. And this is a unique opportunity. These gentlemen are really forward-leaning in their field. You're not going to find them in one spot. In other venues, so I encourage you to engage them after this if you have questions or want to understand the data integration and communications piece. So thank you for your time, and I hope you enjoyed that.